This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Now he's a 75-year-old man, seemingly a routine case, grade 4 nucleus. The side puts are made, the regular steps are done, and now is the time to do the chopping. As I begin to chop, I realize the iris from the side port starts to prolapse out. This is unusual. The eye is soft. The iris is starting to prolapse out. I come out, reposition the iris back again. Decrease the bottle height a little bit and then begin to do the chopping maneuver. Again it starts to prolapse out. This got me suspicious. This looks like a floppy iris. When we explicitly ask that is he taking any medicines for urinary problem, then he comes out with the answer that yes, he's taking tamsulosin for the last 1 year, and which was not forthcoming in the previous history. In the medical history, just mentioned that he's taken medicine for hypertension, and he never mentioned anything about this. Well, this is a common scenario most of us encounter, that the patient is on tamsulosin. We realize this only on the table. This is not an uncommon scenario. Thankfully, the pupil was not small to begin with. It is incised. The pupillary constriction is not a major issue, but the iris is trying to pour in through the side port as well as the main incision. Now, how do we deal with it? Now, if I had known from before, I would have planned it better. I would have made very small side port incisions just for the chopper to go in. But this is a regular sized 1 mm side port, and here this fluid leakage is so much that the iris is going to gush out. So one trick to do here is divide the nucleus using the chopper, and then the second instrument should never be used at all. So the second instrument is there until we just divide the nucleus into smaller fragments, and what is done, it's out. I'm going to hydrate this wound with the BSS, and this wound is plugged. So I'm going to remove the remaining part of the nucleus with just the single-handed technique. The wound is hydro-stitched. Now each of these fragments is pulled to the bag and then emulsified using just the one hand itself, there's a phaco handpiece itself. Here you can see the fluidics are much more controlled, there's no wound leakage, hence there's no propensity for the iris to come out, and eventually each of these fragments is emulsified. Although there is always a risk of the emulsification happening a little bit more anteriorly, more nearer the endothelium, but that's the price which we have to pay to prevent the iris from pouring in out. But this is one small trick whenever we have a situation like this. Try to close off that one wound, use it until only the nucleus division process, and then just use a single-handed technique to remove all the fragments, and it does work well. The cortex is aspirated, the bag is filled with OVD, and then the intraocular lens is placed into the bag. So next time we encounter such a situation, try to use the single-handed technique for quadrant removal. It would be handy. In severe situations, well, obviously if the pupil comes down, we may have to use a pupil expansion device. And then in the worst case scenario, if the nucleus is not divided yet and it's pouring out to the side port, one option would be continue to do nucleus division with the iris in the wound itself. Second option is close this wound, make another very tiny incision so that the chopper can be reintroduced and then the division can be done. For quadrant removal, I would still recommend to go the one-handed way. The only con of using the one-hand technique is there is always a risk of working very close to endothelium, hence the chance of endothelial trauma. So be mindful that you're positioning the probe at the level of the pupil, not above it. And maybe it would be a better idea to use to replenish the OVD frequently enough. So that was it. Thank you for watching and hope you found this helpful.